Hello everybody, I'm Dr. Farhad Najmuddin. You can follow me on YouTube channel Pharmacotherapy Cases. On this topic, I'm going to talk about the management of severe hyponatremia. It is always a common question that how much and how fast hypertonic saline should be replaced, and how should you adjust the rate when the sodium starts to correct. We will have a case to discuss and make some examples of how you dose the hypertonic saline. Here we have a case of 68-year-old man admitted to emergency department complaining about vomiting and an episode of seizure in the past hour. His vital signs are stable, but he's very confused. Lab data soon reports a hyponatremia with a sodium level of as low as 108, and potassium level is normal, creatinine is a little high, and VBG results shows metabolic acidosis with moderate severity. How do you manage this patient? Obviously, you should go first for airway, breathing, and circulation, A, B, C first. But what about sodium correction? To plan to correct the sodium, you should first evaluate the severity of the situation and look for the signs and symptoms of cerebral edema. Actually, in this level of sodium, brain edema may happen, but brain cells have adaptive mechanisms which can be divided to rapid adaptation and slow adaptation. In rapid adaptation, the efflux of sodium and potassium ions to the extracellular space within minutes would happen, but in slow adaptation, some organic osmolytes may shift to extracellular space, and it takes about 48 hours or more. So if the patient has enough time for slow adaptation, he may tolerate very low levels of sodium. So you cannot decide based on the sodium level. You should check for the symptoms of the patient. If there is any symptom of cerebral edema, you should act fast. Severe neurologic symptoms include vomiting, somnolence, neurogenic pulmonary edema, seizure, coma, and potentially fatal brain herniation. These symptoms reflect that you have no time to waste and you should act fast. But there are some potential neurologic symptoms, which means a moderate situation: nausea without vomiting, confusion, headaches. These symptoms reflect that the patient has a good adaptive response and you have more time, and you can start slow and monitor the patient. With minimal neurologic symptoms in chronic conditions, usually malaise, fatigue, cramps, confusion may be seen. But keep in mind that sodium levels less than 110, even in chronic conditions, leads to 10% risk of seizure, which reflects that brain herniation would happen in any time and any minute. When you decide to plan an aggressive strategy to correct the sodium with hypertonic saline boluses or high rates of infusion, you should be aware of the adverse effects that potentially put the patient in danger. Rapid correction of sodium in patients with adaptation leads to brain shrinkage. This shrinkage causes a syndrome called osmotic demyelination syndrome, with central pointing and extra pointing myelinolysis secondary to brain cell shrinkage. This situation is a biphasic illness that occurs in 1 to 7 days after the sodium correction. Initially, patient experiences a recovery because of sodium correction, but later neurologic sequels starts. These patients suffer from seizure, behavioral abnormalities, movement disorders, eventually leads to a phenomenon called locked-in syndrome. In this phenomenon, the patient may lose his ability to move, speak, or swallow for lifelong. So we should know which patients are in high risk of ODS syndrome. Most of the reports are in patients with malnourishment, history of alcoholism or liver disease, hypokalemia, and sodium levels less than 105. Now that we are aware of the danger of rapid correction of sodium, we should wisely select the patients. The patients with severe symptomatic hyponatremia require prompt intervention. Regardless of whether the development is acute or chronic, the goal is to prevent neurologic injury and prevent progression. Increasing the sodium concentration by only 4 to 6 milliequivalents has been suggested to be sufficient. In this situation, administration of hypertonic saline with 3% concentration is the choice. Each milliliter per kg of 3% sodium chloride may rise the sodium level of serum by 1 milliequivalent per liter. So 4 to 6 milliliter per kg of hypertonic saline 3% would be sufficient for the patient. For example, for a given 70 kilograms patient, 100 milliliter of hypertonic saline should be the first challenge, and you continue this challenge with second 100 milliliter bolus, and even you can go for the third one. So you administer hypertonic saline solutions with the volume of 100 milliliter boluses. Challenge the patient for first 100 milliliter, then second. If the symptoms do not relieve, you can go even for the third one. But more than these 3 boluses has a very low quality of evidence, and you may hesitate that. Now imagine a case you have with confusion and vomiting and a report of hyponatremia less than, for example, 120. Now you should decide if these symptoms are related to hyponatremia or even an infection or something else. So you may ask yourself, should I go for a rapid infusion of hypertonic saline, a bolus injection? Don't worry there, because if you correct less than 6 milliequivalents per liter, nothing bad may happen. So what about all cautions that reports you should not correct sodium level more than 8 milliequivalents per liter in 24 hours? So these reports and cutoffs are actually target for absolute value of correction per day. So if you rapidly correct the sodium level less than 6 milliequivalents and then slowly continue with slow correction, and the total correction of that day would not be more than 8, it is okay for the patient. So many practitioners will decide to correct sodium with an hourly manner, for example, 1 to 2 milliequivalents per liter per hour. It is not an issue in first few critical hours that you are starting the correction. Bolus injections of 100 to 150 milliliters over 10 to 20 minutes may be a good choice, and you may repeat that for maximum of 300 milliliters in an average 70 kilograms patient. When you consider hypertonic saline for administration, you may wonder if you can inject it from a peripheral vein or you should have access to a central one. Actually, sodium chloride 3% has a 1026 milliosmoles per liter, and it is roughly the highest osmolarity that you can administer from peripheral veins. So you should choose a large peripheral vein like antecubital vein. And it is good to know that there is a recent report of a good review of literature that shows no significant phlebitis with this concentration. But whenever you use hypertonic saline, you should monitor sodium levels very frequently, at least every 4 hours in all patients, because hypertonic saline is listed as a high alert medication, and if it is not administered properly, it may put the patient in significant danger. In chronic hyponatremia, the cutoff values of the rate of correction of sodium are as follow. At day 1, you should not correct sodium more than 8 milliequivalents per liter. At day 2, the cutoff is lower. You may only allow it to increase sodium by 6 milliequivalents per liter. And at day 3, the cutoff is only 2 milliequivalents per liter. By day 3, you may have a holistic evaluation of the patient, and you even have recognized the etiologies of the hyponatremia in the patient. Until now, you have reports of checking TSH, cortisol level, urine sodium. You may decide what is the etiology, what is the diagnosis. Is the patient hyponatremia related to congestive heart failure, to cirrhosis, to GI loss, loss from burned skin, or may thiazide diuretics or SIADH may be the underlying cause of the hyponatremia, or may the patient have nephrotic syndrome or salt wasting syndrome. So by day 3, you have the diagnosis, and your main goal is to prevent sodium for declining again. Back to our case with a severe hyponatremia with vomiting and sodium level of 108. At day 1, our goal is to rise sodium up to 116 milliequivalents per liter, but you choose to rapidly correct it up to 112, up to 6 milliequivalents. Then you continue to administer hypertonic saline to increase it to 116, a total of 8 milliequivalent that you were allowed. At day 2, you are planning to increase the sodium from 116 to 122, which is equal to a total of 14 milliequivalents within the second day from the baseline of the patient when he arrived to emergency department. By day 3, you are planning to increase it up to 124, which is relatively a very safe level of sodium, and the patient may not experience any symptom of hyponatremia by there. The calculations of the dosing and the compounding of hypertonic saline 3% are actually very easy. When you want to compound sodium chloride 3% when you don't have it, for example, you have sodium chloride 5% access and you have normal saline by your side, so you can compound them with equal volumes. For example, you may compound 250 milliliters of hypertonic saline 5% with 250 milliliters of normal saline. The result is 500 milliliters of hypertonic saline 3%, which is roughly equal to 0.5 milliequivalent per milliliter. Why this 0.5 milliequivalent per milliliter is important? Because it is actually the same as the volume of distribution of sodium, which is 0.5 liter per kg. So when you put it in the equation, you see these two numbers make the calculation very easy. In this situation, each milliliter per kg per hour of administration results in the same amount of milliequivalent per liter per hour of correction. You may change the value of time in the equation. You may make it based on every day. For example, for your case, you want to correct 8 milliequivalent per day corrections. So at day 1, 8 milliliters per kg per day is the sufficient amount. For example, for the 70 kilograms patient, 560 milliliters per day of hypertonic saline is enough. And if you want to infuse it continuously, 23 milliliters per hour is a good choice. In some situation, you may have the patient with hypotension, the patient requires resuscitation, and you obviously use normal saline in this situation. And normal saline contains high levels of sodium comparing to the serum sodium of the patient. So if you use any amount of normal saline, the calculations should be corrected by 3.25 which is equal to the volume of distribution over the milliequivalent per milliliter of sodium in normal saline. So now in our case, we had a 70 kilogram patient, severe hyponatremia, sodium level of 108 milliequivalents per liter. At day 1, we decide to rise the sodium by 8. So first we decided to have rapid infusion of boluses of 100 milliliters. After 200 milliliter infusion, the symptoms of vomiting relieved. The confusion subsided somehow in 1 hour. Now we have a new serum level of sodium reported to be 111, which means 3 milliequivalents rise in the sodium. Obviously, it is not the same as our calculation, but it is a real situation that we have. After that, total dose of day 1 may be 560 milliliters, and we have administered 200 milliliters by now. So we have to continue with infusion of this 360 milliliter remainings over 23 hours. By dividing these two numbers, we have infusion rate of hypertonic saline with 15.6 milliliters per hour. But as I said, we should check sodium every 4 hours because these equations are only some estimations. Actually, the patients may receive loop diuretics, may excrete more sodium, for example, from GI loss, and you cannot consider them in your calculations. So you should check frequently and adjust your infusion rate. The next sodium level report that you had from your every 4-hour check was 112, and the next one was 113. So you saw that sodium correction rate is not that much that you were considering. So you have to decide if you may increase the sodium rate of infusion or not. Keep in mind that if the sodium is increasing, it is enough, and you should not put it in a stress to increase the rate because the symptoms of hyponatremia have been subsided, and you may have so many mixed etiologies for hyponatremia. For example, this patient has nausea and vomiting, which increases the SIADH situation. The antidiuretic hormone releases from the brain, so the hyponatremia may be exaggerated. And by treating the nausea and vomiting, SIADH may be corrected. So the rate of sodium correction may be accelerated in few hours. So if you increase the dose, the patient correction rate may be very high, and you should avoid it. In real world cases, you always have a next day surprise when you correct the sodium in hyponatremia. So the next morning you go to the patient, and the night shift decided to gradually increase the rate of infusion by up to 35 milliliters per hour, and the last sodium level is reported to be 120 instead of 116. So it is higher than that you planned. Now what should you do? You should decrease the sodium level again by infusing, for example, free water to the patient or desmopressin? No, because it is still lower than your target level in second day. So you check the latest episode of every 4-hour check. You see that sodium increased from 117 to 120 by the rate of 35 milliliters per hour. So each 0.5 milliliter per kg per hour resulted to 1 milliequivalent per hour correction, and it is 2 times faster than you calculated. So you recalculate based on these results. Your target level for day 2 is 122 milliequivalents per liter. So you plan to increase only 2 milliequivalents per day 2. So by the correction number you have here, you decide to administer half of the dose that you are calculating at the first time. So for this 70 kilogram patient, 70 milliliters per day should be sufficient for 2 milliequivalents per day increase. The infusion rate is choose to be 3 milliliters per hour, and you continue checking the sodium at least every 4 hours, and you adjust carefully based on that. I hope you find this case presentation helpful, and if it does so, please like this video and subscribe for our future videos, which we will have soon. Please leave your comments below the video and ask your questions. I will be happy to discuss more about this case at the comments.